And they have the kora, for example, which is made from calabash. And they have 21 strings, and they're made from fishing lines, and they're plucked between the thumb and the forefinger. Then we have the balafon, and the balafon is like the xylophone, with 17 to 21 wooden slats that are played with two mallets. And then we've got the djembe, drums which are used for sending messages to people in town, for ceremonies such as weddings, naming ceremonies, or even for healing sick people. So there are many kinds of drums, and you can see a number of them. And we have the djembe here, so I thought we should focus on it. Now the Ashanti live in central Ghana, in West Africa, and they're the largest tribe in Ghana. In each of the villages, the chiefs and the elders maintain traditional customs and ceremonies and deal with disputes. The Ashanti religion is a mixture of spiritual and supernatural power. They believe that plants, animals, and trees have souls. The Ashanti are known for their golden craft and good carving, brightly coloured woven cloth called the kente. And this is what the kente looks like. So we have the Ashanti people, and they come from West Africa, Ghana, Cote d'Ivoire, and Togo. Now, those from West Africa mostly arrived in Latin America as part of the slave trade. Caribbean and Latin America received about 90% of the Africans from West Africa, and about 10% went to North America. The mix of the African cultures with Spanish, Portuguese, French, and British, and the indigenous cultures of Latin America produced many unique forms of language. We have the Garifuna and Creole, the religions like Santeria and Voodoo, the music like salsa and cumbia, and the dance like rumba and merengue. As of 2015, Mexico and Chile are the only two Latin American countries yet to formally recognize their Afro-Latin American population in their constitution. 2015. And this is still so up to today. And this is in contrast with countries like Brazil and Colombia that lay out constitutional rights of their African descendant population. Now, the countries in Europe which participated in the slave trade, we had Britain, Denmark, France, Holland, Portugal, Spain, and Norway all participated in that slave trade. Why did they turn to Africa? Because they had not sufficient labor. They had the labor in the region of the Americas or in the rest of the continents were reduced because the indigenous population were 50 to 90% due to epidemics, licked them out. Evidence of deeply held racist sentiment amongst the Europeans. And in the English colonies, the supply of servants decreased. So let's look quickly at a little bit of the geography of slavery. Enslaved Africans mostly came from areas stretching from Senegal in Africa to Angola. The Europeans divided the area into 5 regions: the Upper Guinea coast, the Ivory Coast, the Lower Guinea, Gabon, and Angola. And that was West Africa. Sorry. I've got some of that here. And this one. Okay. So they divided that area into 5 regions. So then we come to the famous Middle Passage. And the Middle Passage is part of a 3-legged voyage. It began and ended in Europe. It started off with the Europeans moving into Africa, West Africa, carrying a cargo of iron and cloth and brandy and arms and gunpowder. They landed on the African slave coast and exchanged that cargo for slaves. They set sail for the Americas, where enslaved persons were sold or exchanged for sugar, tobacco, and molasses. Of course, they worked on those areas, and then they sailed back to Europe. So the Middle Passage began with a capture and forced marching. The Europeans built about 60 forts along the West African coast. The enslaved captives walked in caravans to the forts, often about 1,000 miles away. Only half survived the death march. Europeans then placed the survivors in underground dungeons until they were forced to board slave ships for the trip across. If we look at some of the statistics, 10 to 16 million people of African origin were transported between 1500 and 1900, approximately 12 million. 2 million died during the Middle Passage. Another 15 to 30% died during the march on the African coast. So for every 100 enslaved persons who reached the New World, 40 died in Africa or during the Middle Passage. The Middle Passage, what were the conditions on board? Enslaved persons were chained together, crammed into spaces, sometimes 5 feet high. Slavers packed 300 or 400 enslaved persons into a ship with little ventilation, human waste, and disease, of course. And this is what the British slave ship looked like, packed like sardines in a can. The destination of slaves, where did they go? 40% went to the Caribbean, another 40% to Brazil, 10% went to Africa, and 10% this way to North America. So now, the countries with significant African mulatto or Zambo populations, as they're called, you have Brazil with 57 million, including the mulattoes, Haiti, Dominican Republic, Cuba, Colombia, Venezuela, Ecuador. The traditional terms for African Americans developed culture, including Garifuna in Nicaragua, Honduras, Guatemala, and Belize. In Brazil, Zambo in the Andes and Central America. Marabu is a term of Haitian origin, denoting a Haitian of multicultural ethnicity. Anansi, which is my friend, who Patrick mentioned earlier on, is one of the most popular characters in West African storytelling. He's a trickster. And the trickster uses animal characters, human features, to help us understand nature. So apart from the burden of slavery, what of the health of those people? And I am not going to give you any Nancy story here. This is fact. Now, if anybody can tell me in this group, what is it we're looking at here? Any idea? Even if you have it, just keep it to yourself, because this is one of the things that we're going to speak about. Just looking at the portfolio of neglected tropical diseases, and this is 2017-2018, this is a list of diseases which affects people in Africa. You have from Buruli ulcer, Chagas disease. Well, Chagas is basically in the Americas, but obviously originally from this continent. Dengue and chikungunya, Guinea worm disease, hydatid disease, foodborne tracheostomy, African trypanosomiasis, sleeping sickness, leishmania, leprosy, lymphatic filariasis, onchocercosis, rabies, scabies, schistosomiasis. All of those diseases affect Africa. But today, we're going to focus on one of them, because we're going to have a number of future discussions where we're going to discuss the rest of them. Because there is malaria too, which is not here. But I don't want to discuss malaria today. I want to look at lymphatic filariasis. Lymphatic filariasis basically is caused by Wuchereria bancrofti, which is a parasite. And this is basically a graph from the CDC showing how the mosquito takes the blood meal from the human being. And, sorry, I don't have a pointer, but if I can show you at the top there, you get a mosquito taking a blood meal, and the parasite enters the body, and those are the parasites in the blood, and then they go into the lymphatic system. So it is in the lymphatic system where those parasites are, and you have microfilaria, which are very small, and then they circulate in the blood, they come through, and the parasite develops. This is a quick idea, a quick graph, just to give you an idea of what is taking place in the body. So you have the infective stage of the larval stage, which is infected into the mosquito, into the human being, and those develop. But the point is that lymphatic filariasis are three closely related nematodes, which are worms. And what we're going to focus on is Wuchereria bancrofti, because Brugia malayi and Brugia timori are basically from Asia. And these are basically transmitted by the infected mosquito. All the parasites have a similar life cycle in man. The adults are seen in lymphatic vessels, and the offspring are seen in peripheral blood during the night. And the offspring, in fact, are the microfilaria. What does this disease present like? You have conditions in which some people never present any disease. You have the acute filarial fever, chronic lymphangitis, lymphadenitis, elephantiasis of the genitals, the arms, and the legs. You have tropical pulmonary eosinophilia, which is a big word, which just means a lot of parasites in the lungs. Filarial arthritis, epididymolysis, which is just basically an infection of the scrotum area, and chluria, which is another condition in which you have a white liquid in the scrotum.
Can I ask a question?
Sure.
That word elephantiasis of the genitals, legs, and all, that means they're long or big or something?
Yeah, and we're going to look at them in a minute.
Okay.
Okay? So that these are basically prevalent in Africa, Asia, Western Pacific, parts of Central America, and South America. In South America, we've got the disease, as you can see, in Haiti, the Dominican Republic. We used to have a little bit in Costa Rica, Brazil, Guyana, and used to have in Suriname, as well as, and this is what Patrick was singing about, the Saramacca lady, because they had filaria too. But as you can see, you have in Africa as well as in Asia. But in Asia, what we have is Brugia malayi, as well as Timori. Globally, you have 1.2 billion people at risk of the disease. About 80 countries, 76 million people with microfilarial carriers, 44 million are diseased, 27 million have hydrocele, lymphedema, which is the swelling of the legs, 16 million, and tropical eosinophilia, about 1 million. Now, as you can see, the parasite is bancrofti, and the mosquito is a Culex mosquito, which breeds in stagnant water. Sorry. Okay, thank you. Breeds in stagnant water, for example, in pit latrines and so on. You have the Culex mosquito, which is the vector of Wuchereria bancrofti. The host factors, man is the natural host. The age affects children between 6 months and a maximum to 20 to 30 years of age, which is the time during which people get the acute disease. It's more prevalent in men, lead, in terms of migration, leads to extension of the disease to non-endemic areas, and immunity may develop after a number of years, but the basis of immunity is not really known. Social and environmental factors, of course, very important because it's associated with urbanization, poverty, industrialization, illiteracy, and poor sanitation. Climate, very important, which it influences, of course, the breeding of the mosquito, the temperature, longevity, terms of humidity as well as the temperature, the development of the parasite in the vector, in the mosquito, sanitation, tongue planning, sewage and drainage, and as I said, the pit latrines are very important in terms of breeding of the mosquito. Laboratory diagnosis, you can find this parasite in the blood, in the thick blood. You take a drop of blood, you can get the filtration method through the membrane, provoking the parasite by giving a tablet, and then you develop the parasite and you get the parasite in the blood within 30 to 45 minutes. Some of the manifestations, you have four types. Asymptomatic amicrofilariamic stage, the asymptomatic microfilariemia, and asymptomatic meaning without symptoms, so that, and then you've got the acute manifestations and you've got the chronic stage. In the endemic areas, a proportion of the population don't show anything. So they, even though they have some degree of exposure to the filaria, some of them who become infected. Laboratory diagnostic techniques are not available to determine whether they're infected or free. So that these people are walking around with parasites, but they don't know. You've got this asymptomatic microfilariemia. Lots of the proportions are asymptomatic for months and years, though they have the microfilaria circulating, and is an important source of infection. And they can be detected during the night surveys. You've got the stage of the acute manifestation, when recurrent episodes of acute inflammation in the lymph vessels, nodes of the lymph and scrotum related to bacterial and fungal infections. So you've got clinical manifestations which consist of filarial fever, lymphangitis, lymphadenitis, and edematous. You've got the chronic manifestations when you have the obstructive lesions, and these occur about 10 to 15 years after the person becomes infected. And this is due to the vessels in the legs and the scrotum and so on becoming filled with the parasite, with the worm, and blocking those vessels, so that what happens is that the legs start swelling, and then you get hyperpigmentation, keratosis, wart-like infections. So you have hydrocele, elephantiasis of the scrotum, the penis, the leg, the arm, the vulva, the breast, and chiluria. And this is what hydrocele looks like. So that you get a swelling of the scrotum due to this is another condition. And can you imagine in the past these patients suffering of all these disease and having no treatment? This is what the disease causes: the penis, swelling. These are the legs of a chronic patient. This is the arm of a chronic patient. The breast of a chronic patient. Chiluria and hematuria. Chiluria being in the liquid in the scrotum, and hematuria blood in the urine due to the disease. So this is what we looked at earlier on, the stages of the leg. So you have the first stage in which you get swelling, which reverses at night. The skin folds are absent, and the skin appears normal. Then you start getting swelling which is not reversible at night. In one leg, for example, the skin folds are absent, and you have the appearance of the leg which is smooth and normal. Then you have the third stage, which the swelling is not reversible at night. You have the skin folds which are shallow, the appearance of the skin is smooth and normal.
Okay.
Again, the fourth stage, the swelling not reversible, the skin folds are shallow, appearance knob-like, as you can see. You've got the fifth stage, irreversible swelling. Skin, the appearance is of the skin smooth and irregular. Then you have the sixth stage, swelling with lots of wart-like lesions on the foot or on top of the toes. And then you've got the seventh stage, in which the person can't move and he needs help with walking. So what we do with the management of these patients, you have to try to prevent transmission, control the morbidity, in other words, relief of suffering. Community level care of those with the disease is important. For the lymphedema, the acute inflammatory attacks, and hydrocele repair. Lots of advances have been made in terms of treatment, and what we've done is to focus not on the individual, but on community with infection. The goal to reduce microfilaria in the community to levels which prevent further transmission. Because as I mentioned earlier on, transmission is due to the microfilaria and not the big worms. So the big worms are in the leg or in the scrotum and causing the blockage of that liquid, and therefore it can't flow and therefore it swells. Drugs which are very important and very useful, diethylcarbamazine, ivermectin, albendazole. And the treatment can be used for 6 months and over a period of time, a couple of years. The DC or DEC is very effective as a microfilarial drug, but it doesn't kill the adult parasites. Ivermectin, another very good microfilaria, very low doses can kill the drug, and is used together with treatment of onchocercosis, which is river blindness, with lymphatic filariasis. Albendazole, it's an antihelminthic. In other words, it kills the worm in the blood, so that if you use the drugs together, you will see that you have the microfilaria, which is being treated by one of them, by the DEC or ivermectin, and albendazole killing the adult worms. So you have this has no effect on the microfilaria, but it does work in combination with ivermectin or DEC. In terms of the surgical treatment that you can have, in terms of the hydrocele, you can have excisions, you can have surgical removal in terms of the scrotum, lymphedema, you can do reduction of the tissue, but you never recover the leg. Treatment and prevention. Early treatment with drugs can destroy the adult worm and logically prevent later development of lymphedema. But once it's established, there is no cure. So that all we can do is do the foot care program, as it's called, and it may offer relief and prevent acute attacks, thus preventing further progression of the swelling. So what's important? Appropriate footwear, so that on the left you see tight shoes and slippers, on the right you have slightly better shoes, in other words, trying to make them more comfortable. In terms of vector control, you can use lots of methods, anti-larval methods, anti-adult methods, prophylaxis. So in terms of the larval methods, you can use chemicals, larvicidal drugs, larvicidal insecticides, for example, organophosphates, and environmental measures are very important, cleaning up pit latrines, septic tanks, and drains, for example. Yeah, the vector control, you can use adult measures to control the vectors using all sorts of insecticides, and then personal prophylaxis using mosquito nets, preventing contact, screening of the houses. So what do we have? Looking in summary, we got lymphatic filariasis. It's a mosquito-borne parasitic disease. You had it in Costa Rica, Trinidad and Tobago, Suriname. But in 2011, WHO removed them from the list of countries. So we have 4 countries in the region with active transmission: Brazil, Dominican Republic, Haiti, and Guyana. 13 million people are at risk of this disease. 90% in Haiti. 5.8 million were treated in 2014, 95% of them in Haiti. Various of the foci have now been interrupted in transmission in terms of Brazil, Dominica, and Haiti, but a number of other areas still exist in those countries. The 4 endemic countries, Brazil, Guyana, the Dominican Republic, and Haiti, have these disability programs in place. So that you can see a lady there sitting with her leg with lymphedema in 2015. So that this disease, even though we've got the drugs, we still have a big problem. This is 3 women in Guyana sitting in the clinic waiting. And this is what they're trying to do now in Guyana. This is drug administration, giving the children albendazole as well as ivermectin or DEC to prevent the disease. Basically, this is the hope, because in the future, if we continue as we have been going for the longest while, we will continue to have this disease, and that is the end of the presentation. Thank you very much.